Good morning, everyone. Welcome you all to today's morning session. Today, the title of my presentation is The Gray Zone, Decision Making Beyond Guidelines. I am today's presenter, Dr. Tasim Akabil, MD PhD resident of cardiology, and my moderator is Dr. Mohammad Taifur Rahman, Associate Professor of Cardiology. I am going to start with the number of total procedures performed last week. Total 266 procedures were performed. Among them, 108 were coronary angiogram, 68 PCI, primary PCI 24, permanent pacemaker 9, and rest were others procedure. Now I am going to show my case. In the 23rd January of this year, a gentleman, 37-year-old gentleman, Mr. X, presented to NICVD with complaints of chest pain for past 4 hours. ECG showed acute ST elevation MI anterior. He was thrombolized with streptokinase. Later, he was discharged with advice to undergo coronary angiogram. Just 7 days after acute MI, he developed severe upper abdominal pain and he went for diagnostic ultrasonography of whole abdomen. But unfortunately, the ultrasonography showed something very concerning. This is the liver and this is his right kidney, and here we can see there is a definite soft tissue mass at the lower pole of the right kidney. On the background of this finding, he was suggested contrast enhanced CT scan of the abdomen, which showed there is a definite exophytic mass at the lower pole of the right kidney. It is inhomogeneous. And this is the mass in the right kidney. CT findings was suggestive of an exophytic right renal cell carcinoma with probable invasion of the parietal peritoneum. He was referred to a urologist. Urologist, along with the consultation with anesthesiologist, sent him for preoperative cardiac evaluation. Preoperative transversive echocardiography showed ischemic heart disease with regional wall motion abnormality with reduced EF. EF was around 33 to 35%. Diagnostic coronary angiogram was also performed, which showed around 95% stenosis in the osteoproximal region of the RCA, around 99% lesion in the ramus, and around 90% stenosis in the proximal LAD with intracoronary thrombus. This is the final coronary angiogram report, which was suggestive of the triple vessel disease, and he was advised for revascularization. Now, keeping in mind in the history of the acute MI just 7 days back, along with the angiographic finding and echocardiographic findings, the anesthesiologist declined to proceed with general anesthesia due to high perioperative risk. Now, what should be the next step? And what can we do for this patient as he is suffering from high-grade renal cell carcinoma, suggestive renal cell carcinoma, along with triple vessel disease, and the anesthesiologist already denied to go for general anesthesia. So what should be our next step? Should we go for revascularization or should we go for surgery? And any comments or any idea from audience?
usually metastasize through the renal vein. The renal vein was not involved yet, but the exophytic nature may involve the parietal peritoneum.
Yes. As the anesthesiologist had already denied general anesthesia, so revascularization was our default strategy.
So, before going for the revascularization, what do you think? What is the chance of perioperative MACE in this patient, for which the anesthesiologist declined the surgery?
Sir, actually, if we consider any active bleeding, that is the major criteria. According to the ARC HBR criteria, any active malignancy within last 12 months, he falls in the category of the high bleeding risk. And if we consider the perioperative risk, and that is the RCRI score, that is also more for his condition. So this is going to be a high risk surgery. And as the anesthesiologist denied, it was more like his personal choice. I cannot comment on that, whether he could...
So it has got two components. Regarding the stratification, risk stratification of the perioperative MACE, it is the cardiologist who is to decide the risk.
He was already on the high risk criteria, sir. We used the risk scoring and he was in the high risk criteria.
So the term used, the anesthesiologist declined.
Yes.
It's not the proper term.
Yes, sir.
It is your duty
Yes,
to decide what is the perioperative MACE risk. That statement could be given that according to this scoring system, the patient has got a perioperative MACE score risk of this percent, likely 10%, 15% risk of perioperative MACE. It is your decision, not the anesthesiologist's decision. Definitely, the anesthesiologist think about his infrastructure.
Sir, actually, most likely he considered from the perspective of
you are not still getting my point.
Yes, sir.
It should be the custom that anesthesiologist should not decide.
এটা আসলে পেশেন্টটা আমাদের কাছে যখন আসছে সে প্রথমে ইউরোলজিস্ট, অ্যানেস্থেসিওলজিস্ট, এনজিওগ্রাম এইটুকু করে আসছে, সেজন্যই ওভাবে বলছে। আসলে জিনিসটা আপনি যেটা বলছেন যে উনি ডিনাইড করবেন, আমরাই ওনাকে বলবো যে দিস পেশেন্ট ইজ হাই রিস্ক, দ্য মেস রেট ডিউরিং দ্য অপারেশন ইজ দিস ওয়ান, সো দ্য অপারেশন ক্যান নট বি পারফর্ম উইদাউট রিভাস্কুলারাইজেশন। সো দিস উইল বি আওয়ার কমেন্ট।
During revascularization, we had to face several challenges. So the first challenge was the choice of the revascularization strategy, PCI versus coronary CABG. As it was triple vessel disease, some may suggest that the CABG can be a good option for him, as there is less chance of strained thrombosis if we have to discontinue DAPT during the surgery. But as the patient has history of acute MI recently, even if we go for CABG, we have to continue DAPT. So we cannot avoid DAPT in this regard. And acute MI is a high risk factor for thrombosis. So regarding this, if we go for CABG, it is going to delay the healing process and it is going to lengthen the waiting period for his non-cardiac surgery. Considering this, we choose PCI. And his syntax score was also less than 22, so PCI was an alternative choice for his condition. Sorry, sir?
রিভাস্কুলারাইজেশন আরটা ছোট করতে পারতেন, সেটা বলতে।
Oh, আচ্ছা, sorry.
Do you know there is an option for going both the surgeries at the same time, CVG and nephrectomy?
Sir, that could be a possibility.
That is one of the best options.
Yes.
One of the best options, because many of the times our bypass surgeons can do non-cardiac surgery at the same setting, if it is feasible.
Probably this is not possible because renal surgery is the approach from the back. For that reason, CABG and the back surgery is not possible. If it is the opening from the front, laparotomy from the front, for that reason this is not viable option?
ইউরোলজিস্ট লাগবে করতে পারবেন করা যায় ওটা অ্যাপ্রোচ করা গেলে ইন্টারপ্রেট করা যাবে নর্মালি যেটা রুটিন ইয়ে করতে যায় যখন অ্যাকসেপ্টেড করে কিন্তু যদি ইমার্জেন্সি হয় বা করতে একসাথে করতে পারে অ্যাপ্রোচ করা যায় ওটা অ্যাপ্রোচ করা গেলে কিডনি অ্যাপ্রোচ করা যাবে
Our next challenge was the stent selection strategy. And what could be our strategy to select the stent? Can we use the usual stent for this patient, or should we choose anything special for this patient? Any idea or any comment from
Raju,
audience?
what is your idea regarding the revascularization?
Before preoperative surgery, only two group of patients.
So this is a multivessel disease.
Yes, sir.
So this patient will be benefited by preoperative revascularization. Question is, the operator and the team has decided to go for the angioplasty of this patient. The question asked by the speaker, which sort of stent this patient should be given?
Choice of the stent, only we can stop the DAPT.
Mic ta kache neন একটু.
The choice of the stent would be the only the early stoppage of the DAPT. This group of stents can
short
be
DAPT
choice.
trial. Those stents who have short DAPT trial, we have to choose this.
The ultimate.
Sarwar, আপনার কোনো কমেন্ট আছে কিনা? This patient has got myocardial infarction. Coronary angiogram was done. He has got a double vessel disease, proximal LED and RCA, and patient has got a renal cell carcinoma. This is one strategy. Another? So three options are in the board. One is the using the drug-eluting stent, in which the trial has shown that stopping DAPT at the end of 1 month or 6 weeks is feasible. Another one is the using bare metal stent, which is now not available in our country at the moment. And is DCBA an option for this patient?
I think DCB is an option, but both the stenosis in the proximal part of the LED, proximal part of the RCA. So we are not so much confident to give the DCB in the proximal vessel nowadays. So far, in the future, we may be confident, but proximal LED, proximal RCA lesion, DCB may be an option, but for my perspective, it is not my first choice.
Let's see what we did actually. Here, the PCI to RC was done. The run-through floppy were negotiated through the proximal RCA lesion. Pre-dilatation was done, followed by a stent, that is the resolute onyx, with diameter about 3.5 millimeter and length of 22 millimeter was deployed in the osteoproximal region of the RCA, and this is the final view following the stent deployment. For LED, the lesion was negotiated with floppy wire. Pre-dilatation was done, and ultimaster stent with diameter of 3 millimeter and length of 24 millimeter was deployed in the proximal lesion of the LED. It was followed by post-dilatation, and this is the final angiographic view following the stent deployment in the proximal LED. Now, why did we choose these resolute onyx and these ultimaster for this patient? There's a trial on this resolute onyx that is called the Onyx 1 trial. It was a multi-center randomized and single-blind controlled trial involving 2,000 patients with high bleeding risk. And it showed that actually this compared the onyx with the biofreedom drug-coated stent. Half of the patients were randomized to onyx group and half of the patients were randomized to biofreedom drug-coated stent group. Both groups were given 1 month of the DAPT. And it showed that onyx was non-inferior to biofreedom drug-coating stent in terms of MI, cardiac death, and stent thrombosis. And actually, regarding the biofreedom drug-coating stent, there is a previous trial that is called the leader-free trial that showed that it was competent with short duration of the DAPT. And here we compared the Onyx 1 trial with the biofreedom drug-coated trial. Regarding the Onyx 1 trial, it is actually the difference between the biofreedom and Onyx stent. The Onyx 1 is actually a stent containing polymer. But biofreedom stent is only containing drug. There is no polymer. So after around 2 to 3 months, the biofreedom work as a bare metal stent. But in case of onyx, it is a biodegradable polymer and it is a biocompatible polymer, and it is a jotaulamus secreting stent, and it has ultra thin strut, and so the balance between the restenosis and stent thrombosis is well balanced in case of onyx in comparison to biofreedom, and it is also compatible with 1 month of the DAPT according to this trial. So we chose onyx for the RCA lesion. Now, why did we choose the master DAPT trial? Master DAPT trial, it is a randomized open-label non-inferiority trial evaluating abbreviated versus standard DAPT in high bleeding risk patient. Abbreviated DAPT here means the DAPT duration for 1 month. So we went for this master DAPT trial, and we went for the ultimaster stent for proximal LED region on the basis of the findings of this trial, as it is compatible to 1 month of the DAPT. Now the timing of the non-cardiac surgery. What would be the absolute time or suitable time to? What would be the suitable time to undergo this non-cardiac surgery? Let's see whatever the guideline says. According to the 2024 guideline for perioperative cardiovascular management for non-cardiac surgery, for time-sensitive non-cardiac surgery with history of prior PCI, with management of DOPT, treated with drug-eluting stent on the background of the ACS, time-sensitive non-cardiac surgery delaying for more than or 3 months at least is class 2B recommendation. Any surgery before 1 month is harmful. But there is no recommendation between this 1 month and this 3-month period, and there is this gray zone. As our patient was suffering from malignancy and CT was suggestive of possible invasion of the parietal peritoneum, we could not wait for 3 months. And as we already used a stent which was compatible with 1 month of the DAPT, and any surgery before 1 month was harmful, so we avoided this 1 month period. And finally, radical nephrectomy was performed 6 weeks after PCI. As the stent thrombosis risk is highest in the first 6 weeks, so 6 weeks was used along with the consultation with the cardiologist and urologist. Now the perioperative antiplatelet management or bridging strategy. How did we manage the perioperative antiplatelet therapy? To continue aspirin throughout the perioperative period is class 1 recommendation. In case of patient with high thrombotic risk, perioperative bridging with intravenous antiplatelet who are undergoing any non-cardiac surgery before 6 months after a drug-eluting stent is class 2B recommendation. This illustration was taken from a review article published in American College of Cardiology. This was the proposed practical approach to antiplatelet bridging. And first we have to consider for whom we are going to consider antiplatelet bridging. In the upper part of this illustration, there are several blue boxes which shows the high risk criteria or high risk chance of thrombosis. If any patient has all of these features, we should consider bridging. In our patient, he has history of acute coronary syndrome following stent deployment within 1 to 6 month period. Along with other risk features, he has history of he's suggestive of renal cell carcinoma, and a drug-eluting stent was used. Now the proposed approach is to stop clopidogrel or ticagrelor 5 days before surgery. And starting of IV antiplatelet at least 24 hours after stopping clopidogrel or ticagrelor. There is a study called the BRIDGE trial on IV cangrelor, which is the only evidence of use of IV cangrelor. There is no randomized trial on eptifibatide or tirofiban. But if IV cangrelor is not available, eptifibatide or tirofiban can be used. Before surgery, if we are using the IV cangrelor should be stopped 1 to 6 hours before. These are okay. Okay, sir. Okay. Whatever we did, aspirin was continued throughout the perioperative period. Clopidogrel was stopped 5 days before surgery. Intravenous eptifibatide was started 48 hours after stopping clopidogrel, that is the 3 days before surgery. Intravenous eptifibatide was stopped 6 hours before surgery, and clopidogrel was reloaded 6 hours post-operatively. And this is the final view of the surgery, that is the laparoscopic nephrectomy. In the left side, we can see that the liver is being dissected away from the renal mass, and the right side, we can see that hemostasis is being secured. In the right side, we can see that there is no almost residual hemostasis. So, final take-home message: modern drug-eluting stent enables safe ultra-short DAPT in high bleeding risk patient. Treatment decision must balance between bleeding and ischemic risk, and clinical judgment goes beyond the guidelines. That is, decision should be individualized to every patient. Thank you everyone for your patience.
regarding the antiplatelet and anticoagulation.
Sir, normally, sir, antiplatelet is stopped. Aspirin is continued, sir, during the operative period, and clopidogrel or ticagrelor are stopped 5 days or 7 days before the surgery. And sir,
Is it safe for this patient of
no, sir,
high
as
thrombotic risk?
Yes, sir. This is a patient of malignancy, so he has high thrombotic risk. So,
Not only for malignancy, 2 stent in the proximal, one in proximal LED, one in proximal RCA.
yes, sir. That's why, sir, eftilagimod was used.
If anything else other than eftilagimod can be used, which is commonly used,
Sir,
but not in our guidelines or in books.
we use heparin during the procedure, sir.
Sir, usually aspirin is continued and ticagrelor, clopidogrel and prasugrel is stopped before the...
So used for
সম্পর্কে আপনার কোনো ধারণা আছে?
Sir, usually IV low molecular heparin is used. Subcutaneous low molecular heparin can be used, sir.
Why not IV unfractionated heparin?
Sir,
It is also more safe because
Yes, sir.
the
Low
half-life of
short-
unfractionated heparin is only 45 minutes. So you can stop it 2 hours before the surgery, then after the surgery you can restart. So this is a viable option, unfractionated heparin.
yes, sir. Yes. Yes, sir. Yes, sir. Sir, conventionally, we use enoxaparin just 12 hours before the... Yes, sir. Yes. Yes.
আপনি যেটা ডক্টর মোমেন বললেন, in this case, heparin has gotten superiority over the enoxaparin.
Yes, sir.
Because heparin is short half-life. আপনি যদি হেপারিন বন্ধ করে দেন, within 6 hours ওর এসিটি, এপিডিটি এগুলো নর্মাল হয়ে যাবে। 6 hours পরে আপনি শুরু করতে পারবেন। আপনি যদি এনোক্সাইপারিন করেন, at least 12 hours লাগবে, তাই না?
Sir, one is heparin can be stopped just before the operation at least 2 hours. Another is heparin has unfractionated heparin has antidote, sir. So in case of any bleeding, we can reversal the action of heparin, sir.
So the against point is heparin is it should be used in continuous IV infusion. So the patient should be hospitalized, and then heparin should be continued with IV continuous infusion. The obsession was there. I was obsessed to manage this patient because I lost my elder brother from SSMC 18. He is a cardiologist, history of acute MI, and put a stent in the proximal LED. Within 1 month, he was diagnosed as a CA colon, and during surgery, he died on the table. So this was not an easy job, I think. So I was obsessed. What best can be done for this patient? And I tried my best to give the best option to the patient. And one option is the CABG with renal mass removal, but this is not an easy job because the surgery can be back, surgery can be in the front. In the same patient, I think the surgeon are not very comfortable to do this surgery in a same setting. The other options was what we tried. We choose the stent from the trials that we can stop the drugs from after 1 month, and then we stop it and proceed for surgery with IV eftilagimod for 3 days, and then stop it and the surgery, and then restart the clopidogrel on the next day.